Good afternoon, everyone. Hi, good afternoon. And I'm Dr. Afshan. So it has been a month since I have met you guys, and I think that today's topic is actually a repeat topic. This was a topic which I took like 1 year back when people who attended were very less. In fact, that time it was the time when we started Everyday Essentials, like free webinar series. So I wanted to repeat this topic because many doctors had actually requested, they had sent message that is this topic available in YouTube or is this topic available as a recording? But at the beginning, we were not recording and we were not doing it YouTube live as well. So I wanted to repeat this topic because it's a very much essential one because we get retreatments in our clinic as a regular. I hope everyone who is present here know me well, and I'm Dr. Afshan. I have been practicing as an endodontist for the past 8 years, and I have a practice based in Tamil Nadu, in Chennai, and in Madurai. So this topic is very closer to my everyday clinical practice because every now and then we get patients who already have done RCT from some other doctor, and we don't know whether to go proceed with a crown or to proceed with a retreatment. Do we have to repeat the RCT before giving a crown, or do we have to go in for an extraction, or what to do? So it's a very questionable thing because it's not a treatment done by us from the beginning, right? So the RCT is done by some other doctor and we are not sure what was done and whether the treatment, the prognosis is good or not, whether the RCT will be painless even after giving crowns, and what will happen is a little bit questionable and a little bit confusing about what to do. Do we have to do RCT for, like, repeat RCT for all the patients who walk in with already RCT done, or do we have to wait and observe, or do we have to go in for extraction and implants? So it's like always a confusing topic for every general dentist, because if the patient is having a pain, we go in for RCT. But if the patient is already done RCT, then it's like it's quite questionable, right? So whether how to proceed. So today's topic is going to be about the same, about how to proceed. And let me not just waste the time. I will just dive into the topic. Okay. So you guys can ask questions in the chat box. I will be answering your questions at the end of the session. Okay, you can feel free to ask any questions in the chat box. At the end of the session, we will have a separate question answer session. Okay, so let me begin with the temptations. Okay, so as soon as I finished my endo, after becoming an endodontist, and as soon as I came out of my college as an endodontist, I had a temptation to save every teeth because I'm an endodontist. I have to save the teeth, right? It took really nearly 1 to 2 years for me to get that reality strike. Okay, so if you guys know me well, my husband is also a dentist. Okay, he's not an endodontist, he's also a dentist. So it was like for 1 or 2 years, it was really like an argument. So whenever a patient comes into our clinic, whenever we do like a joint consultation or like we discuss about a case or something, I always prefer saving every kind of tooth. Okay, so even if it's there is a broken file is there, or like even if there is a furcation involvement or any very huge lesions already RC treated, painful cases, or whatever it might be. So I look upon the solutions, like I will do this, I will keep post, I will somehow save this tooth. So this was my attitude as soon as I came out of the college as an endodontist. But after 1 or 2 years, I started thinking in a different point of view. Okay, because I became a general practitioner as well. Okay, I became a general dentist as well. After coming out and practicing in my clinic, I had to stop a little bit of being an endodontist and I became a general dentist as well. Okay, so as a general dentist, what I think about in general right now is what will be good for my patient for the next 10 years. So this is the attitude which I have right now. So instead of like looking at the tooth and finding a solution how to save the tooth, I think about, will the tooth, if I save it, will it last for the 10 years? Will the patient will not have any problem for the next 10 years? Will I can I promise the patient no pain, no problem for the next 10 years? So this is how I have started looking at all the patients which come into my clinic. That is very important to build reputation and build trust in the patients, right? First thing. So no matter what treatment we do, ultimately the patient is going to doesn't care whether we did RCT, or the patient is not going to care about whether we did implant, or not care whether we are not doing RCT and just filling. Ultimately, what they care about is whether they are painless, whether they are comfortable after the treatment, whether whatever money they have spent, it is not necessary for them to repeat spending again and again. So this is how the patient's attitude is in total. They want a very smooth treatment, a painless treatment, and after the treatment they don't want to face any discomforts, and they want to be like sure that this treatment is going to last for long. I do not have to spend a lot again and again on the same tooth. So this is going to be the attitude of the patient. And yeah, everyone's attitude is same. So if I go to a clinic, I too expect the same. Okay, so I too expect the same. So how do you decide? So that is a very questionable thing. So if it's a normal RCT, yes, in some it's quite easy. If it's not mobile teeth, you can go. If there is crown structure, you can do RCT and save. If it's not mobile, you can do RCT and save. So these things in general, we do understand that whenever there is no prognosis, we do go for extraction. And whenever there is like good prognosis or a good crown structure is there, good bone support is there, then we do go for RCT and save the tooth. So this is going to be a normal scenario where it's a fresh tooth without RC treated. It's going to be because of caries or fracture or anything pulp involved symptom patients, they come to us, we are clear about it. But when a patient comes in with a root canal treatment, so already the root canal treatment has been done, either the patient walks in with pain or without pain. So that is a very questionable misnomer here. So patient can have pain and yet the RCT might fail in 1 or 2 years. Okay, the patient might not have pain immediately, but then also the RCT might fail in 1 or 2 years. So we can never trust that if the patient is not having pain, then the RCT will not fail. It's never like true. Okay. So whenever the patient, even if the patient is symptomless right now, they can have the symptom after a year or something. Okay, so if a patient comes into your clinic with RC treated and asks you for a crown, you give a crown. Okay, and after, like, you think that the RCT looks good, fine, and the patient is painless, but after a year the patient develops pain. Okay, so you need to be able to evaluate the RC treated tooth so that you can weigh in the prognosis, that is whether this tooth will survive, whether this RCT will survive, or do I have to repeat the RCT, or do I have to lead to extraction, or what can I do when it comes to retreatment. Okay, when it comes to already RC treated tooth, how do I evaluate it? So that is going to be the essence of today's session. And starting with the success of a retreatment case. So whenever you want retreatment is something like already a failed case. Okay, so whenever you're going to think about retreatment, it's like it's already failed, some other dentist has failed. So the some other dentist might have a valid reason for that failure, right? So it's not like every time, some dentists, they have that attitude like the other dentist did not do the RCT well. I am very good at RCT. I will do the RCT well, so I'm going to succeed. So it's not like that, doctors. It's not always like that. Sometimes the other dentist might have faced a similar, a little bit of problem. Like there might be a ledge, or the canal might be narrow, or it might be calcified, because of which the dentist might have missed a canal or broken a file or anything. Okay, so it's not like always it's the mistake of other dentist. It might be a little bit of a difficult case. It might be a difficult case in actual itself, because of which the other dentist would have failed. So you need to understand that the failure had happened by other dentists, so there are problems. Okay, so there is going to be problems in that RCT. If that RCT is failing and you're considering a retreatment, it's not like always the other dentist, the previous dentist did not do a proper treatment. It can also mean that the other dentist did face some issues. The same issues you are going to also face. Okay. So you cannot be overconfident. You cannot be overconfident like telling that the other dentist did not do it properly, so it failed. So if I do it properly, it is going to get rectified. That attitude will not help you out. It might help you out to convince the patient, but that attitude will not help you out, because as soon as you start the case, you might also face the same problem what the other dentist faced. Okay, so you have to look it in that direction, look it in that attitude, that there is going to be a problem. The other dentist did face the problem, that's why it failed. So I have to rectify that problem. Okay, only then I will be able to succeed in this retreatment. Okay, instead of thinking of the other dentist did not do it well, that's why it failed, we need to think in such a way that there should be a reason why it failed and why the other dentist was not able to give a good RCT. So we need to rectify that problem, and only then we will be having a successful retreatment, right? So only when you take it in this attitude, you will be searching for the problem, like may it be a missed canal, or may it be a broken file, or whatever it is, or a ledge formation, or a perforation, or anything. You will be searching for that problem, and you will be treating for that problem. If you don't see this in this aspect, you just repeat what the other dentist did. Okay, so you will not be like doing it differently. You will be doing the same RCT again and again. It's going to fail, and especially this happens in missed canal. Okay, so the other dentist would have missed the canal, and you would think that just by correcting the RCT, it's going to work well. But the thing which you have to do is not just finding the canals, like not just treating the same canals again. You have to actually find another one canal. Okay, so that is the actual question, actual challenge in that case. But you never thought in that way. Okay, so you also missed the same canal and again it failed. So you need to be in such a way that there is going to be a problem why the other dentist failed. So we need to rectify that problem and we need to find that cause. So that is how it leads to a successful retreatment. And the second thing which you have to see is this attitude and then your selection. So, whenever you're selecting a case for retreatment, you have to weigh in various factors so that you're able to, see the prognosis. So, if it's already RC treated teeth, already the patient has spent for the RCT to some other doctor, and again you're going to do RCT, already the patient has spent their energy, their money, and their time to do RCT with some other doctor, right? So again, you're going to suggest them to do the same. So when you're going to suggest them to do the same, you have to be very sure that next time it wouldn't repeat. Okay, so you have to be very sure that uh, there isn't going to be any problem. And if at all, if there is going to be any problem, you have to, have to tell the patient about that as well, right? So you need to know what prognosis can a tooth have just by looking at various factors. So just when you're going to look at those factors and select a case properly, yes, okay, this is going to work well, and you inform the patient also if it doesn't going to work well. And if you're going to proceed in such a way, then your retreatment is going to be a success. First thing, you have to be in the shoes of the previous dentist and think why it failed. And the second thing, you have to choose the case properly. And if there are any factors that involve failures, you have to inform the patient as well. Okay, to do a informed selection whether to do a retreatment or not, the patient should know, yes, it might fail again. Yeah, then the patient will think in such a way that do I have to repeat the RCT or do I go for implant? So you need to give the patient the space to choose. Okay, so you need to know what will happen in the future beforehand itself. Only then you will be able to explain the patient, right? So only when you have a very good selection system, you're going to have a very good successful retreatment. So starting with what is considered as a failure. Okay, so when a RCT is considered as a failure. So according to European Society of Endodontics, success is filtered a lot. Okay, success is filtered a lot. If you have to name a tooth, RC treated tooth as a successful, There shouldn't be any swelling, there shouldn't be any sinus tract or opening, there shouldn't be any pain, and there should be no loss of function. And the PDL of the radiograph, that is the PDL of the tooth in the radiograph, should also be normal. Okay, there shouldn't be any radiographical changes. So there shouldn't be any periapical lesion present there or widening of the PDL present there. So your X-ray should look absolutely normal. Okay, so only then it's considered as a success. Literally, even if there is a slight lesion in the X-ray, okay, so there is a pre-existing lesion that is still there in the X-ray, or it hasn't, the root resorption which is still there, it's continuing, or if it's asymptomatic, then it's completely considered as a failure. Okay, so in European society, only a normal looking tooth, even in X-ray, it is accepted as a success. Even if there is a lesion in the X-ray also, it is not considered as a success, it is completely considered as a failure. So now coming to the next thing, this we cannot accept. Why? Because for the lesion to completely heal, it literally takes time, right? To again form the bone, to stop the root resorption, it literally takes 6 months to 1 year. Okay, so it's like considered uncertain. Even if I'm doing an RCT right now today, and the patient had a very big lesion with a sinus tract opening, I treated and I obturated it after too many intracanal medicaments, and the patient is symptomless, and I have obturated it. Even though the patient is symptomless, if I take an RVG, I can find the periapical lesion still there. Okay, so even after a 6 months review, also the periapical lesion is still there. Even after 1 year review, also periapical lesion is still there. But the patient is symptomless. So here, if I am considering the European society, I will tell that this case is a failure because the lesion is not getting diminished or it is not reducing in size. It's still remaining the same, right? So, but this we cannot apply because it varies on patient to patient. So if I'm having a diabetic patient, the healing process is going to be very slow. If it's a leukemia patient, the healing process is going to be very slow. If it's an old patient, the healing process is going to be very slow. If it's a young patient, it's going to be fast. So it varies on patient's healing capacity and the patient's systemic health as well for reformation of the bone. Okay, to for the lesion to get arrested and reformation of the bone, or for the lesion to disappear from the X-ray. Okay, so you cannot trust on European endo society, because we cannot come to a conclusion about success or failure if you consider them. So what happens is the American Association is the vast accepted norms. Why? Because the American Association, they have a term called a healing tooth. Okay, so they tell if there is no symptom and no lesion present in the radiograph, or nothing is there, the tooth looks absolutely normal in X-ray, and as well as no pain or swelling is there, then it's considered as a healed tooth. And if there is pain, okay, if there is symptom, it's considered as non-healed tooth. If the patient doesn't have any pain or any pus discharge or evident symptoms, but the patient still, even if the patient still has lesion when the X-ray is taken, it is considered as a healing tooth. Okay, so the patient will be completely normal. The tooth will not be having any symptom, no TOP, no pus discharge, no pain, nothing. But when we are going to take an RVG, there might be a lesion there. Okay, so there might be a lesion. It is not considered as a failure, it is considered as a healing tooth. So it is just healing. The tooth has started healing, it is healing, you need to give a time for it to heal. So only your non-healed tooth, that is which is having a symptom, is considered as failure, while your healed tooth, that is symptomless tooth, even if there is a lesion present there in the RVG, it is considered as a healing tooth, not as a failed tooth. Okay, so that is why we accept this. Why? Because see, for example, this RCT is treated and it literally took almost 6 months for the complete bone formation, and still if you can see, you will be able to make out the outline of root of the lesion, right? The bone that got resorbed in this region, you can still make out the outline. Why? Because for the complete formation of bone again, it literally takes time. It always depends on the patient's immunity. Okay. So you need to wait at least 6 months to come to a conclusion that the lesion has arrested and the tooth is successful, the RCT is successful. So, so coming to this, so if you can see, there is a huge lesion here, and after extraction, it literally took 8 months to completely, heal in this area. So it takes at least a minimum 6 months to 24 hours for a lesion to disappear. Okay. So in the from the radiograph, for the lesion to disappear, it literally takes minimum 6 months or maximum 12 to 24 months. Okay. And it also depends on the patient's age, the amount of lesion, that is the size of the lesion, and number of roots involved, all those conditions. Okay. So you have to wait. So if I have done a RCT today, and after a year, so for example, a patient has done RCT from some other clinic a year back. Okay. So the patient is not having any symptom, but the patient walks into your clinic, and after a year, and you take an X-ray and you find a lesion there. Okay. It's not necessary that this is a failure. It can be a healing tooth. Okay. So it can be a healing tooth. Maybe the lesion was huge back then and it is reducing in size. So you need to correlate with previous x-rays if the patient has it, or you can contact the previous dentist if you can avail it. Only then you will be able to evaluate and confirm that the lesion is still persisting. Okay. So if the patient is symptomless, even if there is a findings there in the RVG, that is, even if there is a periapical lesion, if the patient is symptomless, then it is not considered as a failure. It is considered as a healing tooth. Okay. So now how do we apply it to the patient? So we have three scenarios here that you might get a patient into your clinic as with a RC treated tooth. So the first most common one is the patient walks into your clinic with a RC treated tooth with no crown. Okay. So with no crown, because the maybe the patient did not have the budget when he did the RCT, or the patient did not go for the crown appointment. So the most common reason for which you will get patient at your clinic, the first one is, I did RCT in some other clinic and I want to place a crown here. I don't want to go for crown, or I traveled so I cannot go to the same clinic. So I have to, they ask us to place a crown. So here the patient comes in without symptom. Okay. It is an RC treated tooth with no symptom and no crown, and patient wants a crown. So we will be first considering five factors. First thing is time. Okay. So was the RCT done immediately or it was done long back? First thing. So if the RCT is done immediately, even without the crown, there won't be any leakage, right? So for example, the RCT was done only 1 month back. So then the RCT without any proper crown coverage, it was there in the oral environment only for 1 month. So there wouldn't be much of micro leakage, much of food particles or food fluids going inside the root canal. So chances of non-sterile environment inside the root canal is quite less when it is a very less time lapse. Okay. So RC was treated only 1 month back. So for example, RC was done 5 years ago. Okay. RC was done 5 years or 2 years ago. I did not place the crown. Okay. Then the chances of the root canal getting infected or the fluids getting into the tooth is more, right? So you need to consider that. After that, the next thing is the sealing. Okay. So if it's a long term, so if it's a short term, fine. The RC was done very closer to the time, like just 1 month back. So the non-sterile environment will not be created yet. So you can proceed with giving the crown without going for re-RCT, right? So next thing, if it was a long term, like I did RCT 1 year back, 2 year back, the next thing what you see is the seal. You see the quality of entrance filling. So when you check the quality of entrance filling, if the entrance filling is a TF, Okay. The patient did RCT 1 month back and the entrance filling was not placed. It was a temporary filling or it was broken away or the literally you can see the GP. Then it's quite that RCT cannot be considered at all. Why? Because it was exposed to oral environment. There was no proper seal. So the failure is inevitable to happen. Okay, so the root canals are not sterile anymore. You need to actually open and you need to irrigate and place intracanal medicament, sterilize it, and then obturate it again. Okay, so for example, the previous doctor had given a composite restoration. RCT was done very well and a composite restoration was placed. And when you are taking an RVG, it looks like completely sealed. Okay. You feel that the quality of entrance filling is very good. In those situations, you can go about doing without going for crown without RCT. Why? Because yeah, chances of getting any liquids into your root canal is quite less because the previous doctor has given a very good entrance filling. So it's not required, right? So no bacteria would have gone inside. It would be sterile. You can believe and go for a crown. And after this, next thing what you check is the obturation quality. Okay. First thing you check the time. If it's less time, fine. If it's a long time, then you check the entrance filling. So if your entrance filling is good, like it is a composite filling, a very good entrance filling is given, then the next thing what you do is take an RVG and check the obturation quality. So now, while checking the obturation quality, it's very important you take an X-ray in all the three angulations so that you will be able to make out whether the previous dentist has missed any canals or not. Especially look for MB2s and any distals if there is one distal canal or two distal canal. So these are the most common places where the dentist can go wrong. Even we can go wrong. Okay, MB2 can be missed, and then in second molar, lower second molar, sometimes we think that we have only one mesial canal. There can be two mesial canals, and in molars, lower molars in general, we can think that only one distal canal is there. Sometimes there might be two distal canals. So you need to check in these regions where commonly we miss out the canals. Okay, so you can check the obturation quality, whether it is kept short or it has been kept beyond, or canals were not obturated properly. Sometimes, some dentists they obturate with 2% GP. Okay, so those things and all, it is not of good obturation quality. Then you repeat the RCT. You tell the patient, even though the patient is not having any symptom, you cannot trust putting a crown there. Okay, why? Because you have to at least get a consent from the patient that if the patient gets pain in future, it's not because of your crown. Because literally I have seen my friend facing an issue like this. Like RCT was done from some other clinic, and the RCT looked fine, so she went on and proceeded with the crown. Okay, and after placing the crown, after 2 weeks the patient started having pain, and the patient was like, it's because of the crown. Okay, so I had to actually do an access cavity through the crown. I was called for consultation, and I had to actually do access cavity through the crown, and I did retreatment again. And we had to do it with the crown because the patient was very apprehensive. So since then, whenever I'm going to place a crown on RC treated tooth from some other clinic, I always take precaution. Why? Because, like the patient blames us. The RC was done by some other dentist. Pain was because of some other dentist, but they blame us because we have given the crown and the pain has come after that. So they blame us. So it's always important. We have to be very clear about the RCT's quality. So if the obturation is not proper, so the problem was the previous dentist has kept it beyond something like that. So because of which the patient had pain. So I had removed it and did an re-RCT. Okay. So you have to check for the obturation quality. If it's not good, then you suggest repeat or at least get a consent from the patient. Okay. So the RCT doesn't look fine. If after crown, if it fails, I am not responsible for it. Even if the RCT is good, also you get a consent. That is the safest thing to do. Okay. Then you check for a periapical and pedial condition. So after checking all these conditions, even if you have a periapical lesion, a mild lesion or something, or a mild pedial widening is there. Okay. then it is accepted if the time lapse is only within 1 or 2 years. Okay. So if the patient has done RCT 1 year back or even within 2 years, then if there is a lesion, it can be accepted. Maybe the lesion was too huge, or the patient is diabetic, or something like that. So the lesion is still persistent, or it is just healing. Okay. So if the time lapse is more than 1 year or more than 2 years, then definitely it's a failure. Okay. So if the time lapse is more than 2 year, like I did RCT 5 years back, and then even after 5 years, if you're finding a periapical lesion or widening of perial, then the tooth can be considered as a failure and you need to repeat the RCT. So whatever, and another thing, the fifth category is to look for broken file, missed canal, or any vertical root fractures or perforations. So vertical root fracture, usually the patient will come with pain. So it is not applicable in this scenario, one, because the patient is not having any symptom. So usually, sometimes even if the patient or if the doctor, the previous doctor has obturated with the file, or even with a missed canal, or perforated somewhere or there, the patient will not have symptom immediately. Okay. But without knowing these, if we suggest retreatment, we will get stuck. Okay. So if there is a broken file inside, and that previous dentist had like just obturated with a file, and sometimes the sealer gets coated in that broken file, and it literally doesn't it's not ever at all visible also, especially when you're using a resin sealer or silicon based sealer and all. Even this files also, they get covered with a sealer, and it looks totally trans opaque, and you're not radio opaque, and it doesn't look like a separate file, it just merges with the GP. So you will not be able to make out broken files in some cases. Without knowing that there is a broken file, you start the retreatment, and after too much of removing all the GP, you get to know that there was a broken file. Now you need to encounter some other problem also, retrieval of the broken file, and the patient will not trust that the previous dentist broke it, because you have started the treatment and then only there is a broken file. So now you have to tell, we don't know whether the previous dentist has already informed the patient about the broken file or not. So if you are the first person to tell about the broken file, most probably the patient will think that you only did it. Okay. So you need to look for all those things as well, whatever the previous dentist has done, whether there is any broken file or a perforation present there. So after that, so in case if there is a, like, you're not able to make out clearly in RVG, especially your VRF, or in cases where the broken file merges with the GP and all, you need to take a CBCT. So whenever you're considering a retreatment, so if you're thinking about starting a retreatment, so if you think that there is a problem in this obturation quality, or it's like too much of time had happened without the crown, or the quality of entrance filling is not good, so you're going to repeat an RCT, it's always better you take CBCT. Okay. So if you're thinking about retreatment, a CBCT should be a mandatory thing. Why? Because in CBCT only you will be able to make out VRF and sometimes missed canals as well. So if the missed canal was happened, it is evident that in RVG it wasn't visible clearly. Okay, right? So that's why the previous dentist missed it. So if it was very much visible in the RVG, then the previous dentist would have also obturated that missed canal as well, right? So it was not visible clinically as well. So let's say the previous dentist was also a very good dentist who did who is good at doing RCT. Okay. And he did his best work, but the missed canal was not visible when he or she did the access cavity, and it was not visible in the X-ray as well. It was overlapping, because of which it was not visible. So same thing might happen to you, right? So it's always better you take a CBCT, because in CBCT your missed canal will not be missed at all, they will trace it. And also broken file also, if it's there, you can see, and VRF especially, it can be detected only in CBCT. Now, coming to CBCT, endo CBCT is different from what you get for implant. So, implant, your field of view is going to be 8 into 8. Okay. For an endo CBCT to detect VRF, to detect missed canal, especially to detect VRF, you need a small FOV. Okay. So, wherever you're sending your patient for CBCT, you need to ask the scanning diagnostic center whether they have endo, the field of view should be 4 into 4. Okay, 4 into 4. Only then they will be able to detect VRF. Okay, some diagnostic centers, they will just take and give you. Okay, but it will not have that much of detail. They would not have traced the canal and all. But the diagnostic centers which have FOV, that is field of view for endo, that is 4 into 4, they usually get points. Like they literally trace the canals. Like I get a report with points. Like there will be like, this is the pathway through which the canal is going. So they would have traced every inch of the canal and how it is and everything. Because the field of view is very small, they are able to see even small slices. So when the field of view is very large, they will not be able to see this slice. So if you want to take a CBCT and if you want to see very small cracks and everything in a tooth, then your field of view should be in such a way that a single tooth can be sliced. Okay. When you have a field of view of 8 into 8, three tooth or two tooth are getting sliced. Okay, so an entire region will get sliced. In those slices, you will not be able to make out very clearly whether there is a broken file or or vertical root fracture is there. So it's very important when you're sending CBCT, you call and ask your diagnostic center whether they have field of view of 4 into 4 or field of view that is necessary for endo, for tracing canals and all. Only then you send them to the training center, to that diagnostic centers. Okay, so to make out whether there is any problem like this, a missed canal, you need to take CBCT. It is mandatory. So if you're considering a retreatment, it's always better, or maximum, it is the best thing to do is send for CBCT, get the CBCT report, and then start your RCT, the RCT. Okay. So whenever you have a problem in the first four factors, like your time lapse or quality of entrance filling, which is like completely controllable. So you just need to repeat your RCT. When you're going to do it correctly, it's going to be restored. Okay. So whenever there is a problem in the entrance filling, you just need to sterilize the canal and obturate it. Or when obturation is not done correctly, just going to correct it is going to rectify the problem. But when you have a problem with this, when you have a broken file or a missed canal or a VRF, you need to consider some more factors as well. Okay. So whenever you're going to have a missed canal or a perforation or a broken file, number of appointments are going to increase. Okay, number of time spent is going to increase. So if you want to retrieve the broken file or if you want to find the missed canal which is calcified, it's going to take time. So you need to tell the patient about all these risks and how many appointments it's going to take, and you might even cost more, right? So if you're going to retrieve a broken file or find a missed canal, or if it's a calcified one, you might even charge more, right? So you need to get the patient's concerned, and only if the patient has an attitude to save the tooth, no matter what, then you get into the retreatment. If the patient doesn't have the attitude, like just extract or something like that, you don't force the patient, because the patient has already undergone this RCT procedure. If you're going to repeat it again, if the patient is not having a positive attitude, it's better to extract than to do retreatment. Okay, so just inform the patient about all the risks, and if the patient is willing to do the treatment, then you go about doing the treatment. If not, you just skip it or do whatever the patient wants. And then sometimes, if there is a broken file or a missed canal and the patient is asymptomatic, you can just observe. Okay, you can just observe it for 3 or 6 months. If it's like the quality of entrance filling was not good, okay, that was the problem there, and then you found there is a broken file also, instead of immediately telling retreatment, you can just place a entrance filling, a good entrance filling, and tell the patient we will just observe it for 3 months, and after that, if you're symptomless, we will go for crown. Okay, so you can just observe. Whenever there is a problem, you immediately don't jump in for retreatment, because this problem is going to be a big thing to rectify. Okay, if there is a broken file, you have to retrieve it, you have to treat it. Instead of, if there is no symptom at all, why do you need to do it? Let's just leave it like that itself. Okay, so instead of disturbing it, you can just leave it like that itself. You can just observe it. Only if the patient becomes symptomatic, then you can proceed with the retreatment. Okay, so consider retreatment and restore. So these two things you have to consider whenever you have a broken file. If the patient is having no symptom, okay, if the patient is having no symptom, only if the patient has a good attitude towards retreatment, then you do it. And the second thing is, whenever you have a problem like this, it's better to leave it alone, okay, than to disturb it. So you just observe. Only if the patient becomes symptomatic, then you do retreatment. Otherwise, you can just continue with the same RCT. You can inform the patient and you can go about and give the crown, okay, if the patient is asymptomatic. So now coming to a scenario two, where the patient comes with a RC treated tooth with symptom, okay, with or without crown, that doesn't matter here. So here the patient is coming in with the symptom only. The patient is not coming in for a crown. They are coming in because there is pain. So here the first thing is, again we will consider all these things. So whenever we have a problem in the first four, there won't be a problem at all, okay, right? So if the patient comes with symptom, if there is a problem in, too much of time had happened, 5 years back RCT is done, or entrance filling not good, or obturation not done correctly, still lesion is there. So all these problems is can be corrected by us. So just by repeating RCT, we can just retreat and restore. But whenever there is going to be because of missed broken canal, broken file, or a missed canal, or vertical root fracture, then you need to consider some more factors, extra factor as well. So if it's a vertical root fracture, retreatment is not possible at all. Vertical root fracture happens only in RC treated tooth. Why? Because whenever you're going to do, RCT in a tooth, we prepare, right, 6%, 4% files. So because of which the remaining dentin thickness becomes very less, and when the patient bites something hard, there is a vertical root fracture, which you cannot never correct. Okay, so literally you have to extract. If there is a vertical root fracture, you have to extract. There is no option of retreatment. But when it comes to perforation, also the same thing. If the perforation is very huge, if it is irreparable, okay, it's like two, the roots are separate completely, the furcation is completely involved, in those conditions also you cannot restore properly, okay. So you need to consider the patient attitude, like the first scenario as well, whether the patient is willing to repeat the treatment or go in for extraction. Whatever the patient wills, you have to do it when it comes to retreatment, because patient attitude is very important. Only if the patient is cooperative, you are able to give a good retreatment, because you have to give many appointments for retreatment. So the patient should be cooperative. If not, you have to do whatever the patient wants. And next is your difficulty level. So if it's a broken file, you have to consider extra factors like, can we retrieve it? Okay. How can I bypass it? So what should be my treatment plan now? How can I go about? So those difficulty factors also come in here. So you need to consider those difficulty factors. Only if it's a favorable one, yes, I am able to retrieve the broken file. It is a favorable broken, the spot where the file has broken is favorable, then you go about doing a retreatment. So even perforation also we will be able to repair, only then you go about retreatment. And the third thing is your crown structure. Okay. Sometimes if the patient comes in with already RC treated tooth and with symptom without crown, so most of the time whenever a proper coronal seal has been kept, okay, even though inside broken file or missed canal or whatever might be the problem, if a proper seal was kept, mostly it doesn't fail. Okay. If the crown is completely covered and there is no liquids or fluids going inside the root canal, mostly there won't be failure. Even if there is a broken file inside, or there is a missed canal inside, or even if there is a perforation also, failure, chances of failure is quite less when there is a proper covered crown has been given. Okay. So most of the failures, okay, already RC treated tooth with the pain happens only when the crown is not given. Okay. So when the crown is not given, when it is a long term, mostly the tooth is broken. Okay. Crown is broken. So you need to check whether the crown structure is still there. You will be able to give a post or not, whether it's necessary or not. Whether if it's the crown structure is not there, you need to check for the biological width. If you are doing crown lengthening to get that crown structure, can you do crown lengthening? Biological width, you need to violate the biological width. So all those considerations should also be done. And then the PDL status. So whether the tooth is mobile or not. So if it's mobile, then no consideration of retreatment at all. And then your economical factors. Since this broken file retrieval or your sometimes finding missed canal that is calcified or repairing perforation require high instruments, high level instruments, like you need for retrieval of broken file, you need file retrieval, microscopes or whatever. So you need to charge more, right? You need to use ultrasonics and all. So you need to charge more according to it. So whether the patient can afford it. Okay, so economical factors as well. So if I'm going to do a retreatment, I need to use even if I'm doing a perforation also, I need to use a MTA repair material, right? Root repair material there. So I need to charge the patient. So economical factors also play an important role. Retreatment is not cheap. It's very costly. Okay. So retreatment, you need to charge the patient more. So if the charges can be afforded by the patient, then you consider retreatment, and also majorly the healing capacity. Sometimes, even if the RCT is good, also, even if all the factors have been good, even if the RCT is good, the previous dentist has done it very well, sometimes the RCT might fail because of systemic conditions. When the patient is having uncontrolled diabetes, when the patient is having uncontrolled diabetes, failure is inevitable in some, in some cases. Even without caries also, the patient develop lesions because of endoperio lesion. It might be because of primary perio and all. So when if the patient is having uncontrolled diabetes, or when the patient is having a leukemia patient and all, they have compromised immune system and delayed healing, because of which sometimes even if everything is done correctly also, it might lead to failure. In those conditions also, you need to reconsider retreatment. But we need to do retreatment in those cases. If it's uncontrolled diabetes, you cannot extract. At least you can do retreatment, and you can just try to arrest the lesion. Extraction is totally contraindicated when it is uncontrolled diabetes. So sometimes we might have to do retreatment for symptomatic relief, but you cannot promise the patient that prognosis will be good in those conditions. Okay, so it is just a symptomatic relief, because extractions cannot be immediately possible in uncontrollable diabetes. So the only option is to open and place intracanal medicament for the symptoms to arrest. So in those situations, you can do a elective retreatment, but you cannot promise a good prognosis. That is, for 10 years, you will never have problems. You cannot promise that. You cannot tell the term to the patient. You have to explain the risk as well. Okay. So coming to when extraction is a better option. So whenever, so considering all these factors, so when there is a bone loss, or when there is a vertical root fracture or fractured roots are there, or whenever the crown structure is completely compromised and already failed a retreatment. So it is like third retreatment. So already RCT is done, failed. The second time also some other dentist did a retreatment, and then also it failed, and the patient has come to you the third time. Okay. So in those situations, it's always like maybe the failure is inevitable. Okay. Or you need to be very precautious why the failure happened, because the two dentists have failed. We cannot underestimate any dentist here. So we don't know what's the cost. So you need to think in such a way. So sometimes if it's like too much risky, you need to avoid retreatment and you can go for extraction. And then your anatomy or canal blockage. So for example, if it's a missed canal and the missed canal is calcified, because of that there is a failure. If you're not able to negotiate the canal, or you think that it is an inaccessible, like for example, RCT done on 8 or a buccoverter tooth or something, inaccessible anatomy is there. Because of that, if the failure has happened, it's better to go for extraction rather than repeating the RCT. And especially when there is a file breakage. So whenever there is a file breakage and patient is not having any symptom, even if the file is in the bone, okay, file is beyond the tooth, inside the bone, if you see it also, if the patient is symptomless, you can just leave it there. You should never disturb a patient with file only and until if the patient is symptomatic. And if the patient is symptomatic, and if a patient comes into your clinic with pain and also with a broken file, you can consider four things. Even if you're not going to do file retrieval yourself, even if you're going to call in a consultant or you're going to refer the patient to a consultant or anything, even if you're doing those things also, there are some criterias which you can look for in the RVG, through which you can actually analyze whether this file can be retrieved or not. Okay, so it can be retrieved easily or not, and according to it you can talk to the patient. Even if you're referring the case also, you will be able to get a clear picture whether this file can be done, retreatment can be done or not, whether you can refer the patient for retreatment or you can just go in for extraction. Okay, so those conditions you need to look in for four things. One is where the file is located. The second thing is the path of exit, so which I will explain in the next slide. So next is the size of the file and then the curvature of the root. Okay, so location of the file, path of exit, size of the file, curvature of the root. So if there is a file inside, if the patient is asymptomatic, you leave it. You undisturbed, observe. Patient is asymptomatic, just don't do anything. If the patient is symptomatic, only then you go about and consider retreatment. And when you're considering retreatment, you need to check for all these four factors. The first thing is size of the file. So whenever the size of the file is big, okay, a larger sized file, it will bind very well inside the canal. For example, if you are breaking a F2 or F3 inside the canal, it binds very tightly inside the canal or something like that. It's quite difficult to remove. But if it's a small size file, okay, if it's a very small size file, bypassing is quite easy. For example, can you see this file? It's a huge file. So if I'm bypassing here, I will do BMP here, and literally the remaining dentin is going to be very thin. Okay. So when the patient is going to bite, it might even fracture. The root might even fracture and lead to retreatments, lead to failure of retreatment. So you need to consider whenever the size of the file that is broken is huge, bypassing itself can reduce the amount of dentin. And retrieval, usually if it's very much too much of binding can happen, because of its retrieval might be quite difficult. But when it comes to a smaller size file, it's quite easy. Either you can bypass, because there will be too much of dentin will be there. So even if you bypass also, dentin loss will not be there. And even if you're trying to retrieve the file also, you will not be, you need not trough more dentin. So you can preserve dentin as much as possible. And when you're going to mostly irrigate itself, it will be a little bit loose and it will come out. Okay. So smaller size files are quite easy to remove than your larger size files, and it's usually the larger size files that break because of binding. Okay, and also we are very careful in putting our S1 and S2. We take new files, but we don't usually discard our F1, F2, F3. Okay, because it's a larger size file, we use it repeatedly, because of which those are the files which break mostly. Okay, so larger size files are quite difficult to remove than your smaller size file. And then you need to check for the location. Okay, so whenever endodontist, okay, who is like experienced in removing a file, they will first, what they do is enlarge the canal, and then through the microscope they access the file and they pull that file out. So now when you're going to have a file in the apical region, you need to enlarge it till here, right? So only if I'm going to enlarge the canal like this, then I will be able to visualize and I will be able to retrieve this file. So now while enlarging this canal, what happens is this remaining dentin becomes very less. So especially if the dentin becomes very less in this region, in the curvature region and all, it's going to lead to fracture of the root. So at the end, what happens is I will be able to remove the file. I will take the file out, but the patient will be dead. Okay, operation is success, but the patient is dead. That is, I would have removed all the dentin over here, because of which, even though I removed the file also, I did a retreatment also, the tooth root became very weak and it would break eventually in masticatory forces. Okay, so many dentists, like many people in Instagram, you might look into file retrievals. Okay, but file retrieval tooth becomes very weak. So that is the reason why Whenever you don't have any symptom, you obturate with the file, you try to bypass. Only when you're not able to do all these things and the patient is still symptomatic, your retrieval of the file is going to be the last option. Why? Because retrieving a file will compromise tooth structure. Okay, it will compromise tooth structure. And when you're retrieving, your dentin in the root is going to get reduced. Only then you will be able to retrieve the file. Okay, so you need to consider if it's a curvature, then when you're going to remove too much of root, too much of tooth structure, then it might lead to fracture. So you need to consider that factor as well. And the third main factor is the path of exit. So if you can see here, this file, if I'm going to get a clear path here, okay, I have created a very good, I have drilled inside with my ultrasonic or a GG, I have enlarged, and when I'm going to give a ultrasonic activation, this file will not come out. Why? Because this direction where the file needs to come out is in this direction. So even if I vibrate this file also, it will try to come out, but it cannot come out, because if it tries to come out, it goes in this direction. It cannot turn and come in this direction. So because of which this file will stay stuck inside even after too much of trial also. I need to go inside and pull this file out. Only then I will be able to retrieve it. Either I need to pull this file, only then I will be able to retrieve it. Just ultrasonic activation cannot make it come out. Okay. The second thing here, you can see this file, its path of exit is in the direction towards the pulp chamber. Okay. So now if I enlarge this, and if I'm just going to give a ultrasonic activation, with the vibration itself, when the file tries to come out, it will come out in this direction. It might easily come out. Okay, so when your path of exit, that is the file is oriented in such a way that it is facing or it is coming out in the direction of towards the pulp chamber, it's quite easy to remove than the ones which are in another direction. Okay, so you need to consider all these reasons and all these category, and you can weigh in and tell your patient how difficult it is to remove this file, how whether it is possible or not. Any file can be retrieved. Okay, with the help of microscope and ultrasonic, it is quite easy right now to retrieve any file. Okay, but the problem is whether the tooth will be good or not after retrieving the file, whether the tooth prognosis will be good, whether the root structure will still be there. Anyone can go inside, enlarge this, and go inside with the help of microscope, pull this file out. But it can, after doing that, whether the root structure will still be there, whether the remaining dental will still be there, and under masticatory forces, this root can withstand the masticatory force or it will fracture. So that is the questioning here. Okay, so we need to remove the file in such a way that too much of tooth structure should not be removed. Okay, so all these factors. So whenever there is a curved canal, we need to remove too much of tooth structure. Whenever the path of exit is not in the favorable category, then we need to remove too much of tooth structure. When it's a huge file, then also too much of tooth structure needs to be removed. So these factors will influence whether the file can be successfully removed and the prognosis will be good or not. Okay, so when you have a broken file, you need to consider all these factors, and only then you need to suggest retreatment. Sometimes it's better to get an opinion from an endodontist as well. Okay, so broken file, consider it only when it is symptomatic. If it's not symptomatic, just leave it there or try to bypass. Never try to retrieve it. Only if the patient is symptomatic and you don't have any other option, then you go for retrieval. Okay, so some files like this, even if it's a larger size also, it can easily be retrieved. Okay, so apical region is quite difficult. Why? Because you need to cut in and you need to cut all these dentin and then you get access to the file. But here the file has been broken till the middle third. So you just enlarge in the coronal third of the root. You are able to visualize the file, you create a trough and you can just pull this file out. Okay, so when your file is very large or it is broken in the middle third or the coronal third, it is easier to remove. If it's broken in the apical third, it is difficult to remove. It's a small file that is short, below 6 mm or below 3 mm. It is quite difficult to remove. If it's larger, like 6 mm, then it's easier to remove. And the orientation of the file, if it's towards the pulp chamber, easier to remove. Not towards the pulp chamber, it is difficult to remove. So these are the factors which you need to consider. Apical third, difficult. Smaller size, that is your length of the file is less than 3 mm, it is difficult. More than 3 mm or more than 6 mm, it is going to be very easy. 3 to 6 mm, it is going to be easy. It will be like till the middle third, you can pull it out. Location, coronal third and the middle third of the root is going to be easier than the apical third. And final thing is your path of exit. So if your path of exit of the file is towards the pulp chamber, quite easily it comes out. If it's not towards the pulp chamber, it's difficult. If it's in the curved route, it's difficult. It's straight route, it's easy. So these are the difficulty levels of file retrieval, okay, that you can access when you're planning for retreatment in your patient. And coming to the cases, so this is a case where the patient had done RCT and it had failed, or the crown structure has broken away. Can you see? So here the patient wanted to repeat the RCT, but then also I did not do RCT because even if I'm trying to do crown lengthening also, can you see the level of bone? Okay. Can you see the level of bone? I am supposed to do osteotomy and create that biological width, and then only I will be able to do crown lengthening. So I don't believe in osteotomy and all. I don't take too much of risk. So I did not suggest retreatment. I suggested only extraction for this tooth. Okay, I did not place post or I did not do retreatment. So whenever the coronal structure is compromised, even though the case is very easy, if you are not able to replace the coronal structure, if it's not suitable case for post, then you consider extraction rather than going for retreatment. Okay. And then this case, this is a patient from Ireland actually. So this patient had a broken file here and also missed canal. Patient did RCT in India only, and they went back to Ireland. And in Ireland, suddenly the patient got pain. So the patient had to go there for emergency, and there they take CBCT no matter what. So the patient had a very clear CBCT report. The problem was very much visible. It was a missed canal and also a broken file in the palatal. So now I know the problem and I was very confident in doing retreatment for this patient. Why? Because the missed canal tracing has been clearly done and I will be able to find it. And also this broken file here also, even if I'm not able to retrieve it, since the lesion is huge, my plan was to open, do apicectomy, remove this part of the root itself to do apicectomy here and proceed with the retreatment. Okay, a retrograde filling with MTA and proceed with the retreatment. So this was my plan here. So even if I'm not able to retrieve like this, I was thinking about apicectomy because only the small size file, only 2 mm was broken here and the lesion was also very huge. So let me just do apicectomy. The file will also come out and we can just proceed with the retreatment. So I was very clear and I was very confident in doing the retreatment, but the patient was not willing to do the retreatment. He had gone through too much of pain in Ireland. Okay. So he was not even trusting on RCT. Even if I told him that I can do very good RCT, you won't have problem also. The patient's mindset was totally not towards RCT and he was like literally towards implant only. His mindset was to extract the tooth, place implant, be problemless. So that was his only, his mind was towards that only. So what we did was we did the extraction and placed implant. So you have to sometimes, even if you think that you can do retreatment, you need to do what the patient wants because ultimately it's his tooth. Okay, he should be the final one to decide. So you cannot force the patient. Even though I was confident, I told him only for 10 to 15 minutes we can be doing. If I force him, what will happen if I force? Like if I tell him I can do it, there won't be any issues at all. I'm very confident. Every time it doesn't go the same way, right? So what if I'm not able to retrieve the file? What if I'm not able to, do apicectomy and clear the problem? What if the patient has the pain once again? Okay, so you can never be 100% certain when it comes to patient's treatment. It's multifactorial. So it's always better to leave it on the patient to select the treatment rather than forcing a treatment on the patient. So that is how I do. So the patient was like towards implant only. So we went for implant even though the teeth can be treated by me. So coming to a next one, which is a very straightforward case, if you can see, the problem was like when you see it was a little bit of narrow canal, and there is a lesion there, and literally the previous dentist hasn't filled anything. Okay, so here for me, it was a very clear picture that the entrance filling not there and obturation material not there. So it was a very clear case. Just by doing a retreatment, it can be rectified. So placed intracanal medicament, then just obturated it. Okay, so this is going to be a straightforward retreatment, no complicated ones. And coming to this, okay, so here the patient, I think the obturation material was placed properly, or there was root resorption, open apex was there, and the previous dentist did not do apexification, that is, did not keep a barrier here. Okay, and did obturation like that itself, because of which there was a failure. Okay, so whenever there is a open apex, so open apex can happen because of two reasons. One is when it is a young patient, the root is still forming, those patients. The second patient is when there is apical resorption. So apical resorption, when it is happening, you might encounter open apex. So this open apex needs to be filled, that is apexification should be done, only then you will have a proper seal. So you should have two seals are very important in a successful RCT. One is either you give a proper crown, okay, crown structure completely sealed, coronally it should be completely sealed, and apically also it should be completely sealed, only then you are going to have a successful RCT. So apexification is a must, and the previous dentist did not do apexification, because of which it failed. So now the problem was I tried to remove the GP. So even after removing the GP also, I was not able to retrieve this part of the GP. Multiple times I tried also, it got pushed there. So now even if the GP goes beyond, okay, it's not necessary that you need to remove the GP or you need to remove the file. Okay. So for example, if the GP is here, or your file, broken file is in this position also, it's not necessary for you to remove. Why? Because this is a completely a zone where you have regular blood supply. So your body's inflammatory process would have started, and it would start to engulf the foreign object. Okay. So our body would actually engulf the foreign object, and the inflammatory process will actually slowly it will subside. But the problem here was the inflammatory process did not subside. The patient continued to have pus discharge, and the patient continued to have infection. Okay. So I on keeping regular intracanal medicaments also, the infection did not subside. So I had to do apicectomy. I opened it, I curetaged it, and then uh, did apicectomy here, kept a retrograde filling material, and by doing curettage itself I was able to remove that GP as well. Okay, did apicectomy, kept a MTA, and then closed it. So here you can see a retrograde filling material, that is your MTA here, and RCT done, and your after 1 month completely this lesion completely disappeared, and the prognosis was very good. After 1 month we went for crown. So whenever you have a persistent lesion, so why I did apicectomy is not to remove the GP. It was done to remove the lesion. It was a persistent lesion. It was not getting arrested even after 2 months of intracanal medicament also. Pus discharge was still there. So I opened it, and while opening it, I took the GP out as well. Okay. So to remove the GP, you need not do surgery. To remove the GP or to remove the file, if the patient is asymptomatic, you do not do any surgery. Okay. A normal inflammatory process will happen, and it will just engulf the foreign object. Our body will accept it. But whenever the patient is symptomatic, then you do apical surgery and you remove the foreign object. And coming to retreatment, so whenever you're going to do a retreatment, my suggestion would be to use rotary. So H files can remove GP which is loose. Like if the obturation was done with zinc oxide eugenol, you can remove it with H files. Okay, so that is why H files are suggested in your textbooks. But right now, the sealers which the dentists are using is usually bioceramic, MTA sealers, calcium hydroxide sealers, or resin, or even silicon sealers. So these sealers cannot be removed with your H files. Instead, your H file will break. Okay, you went to remove the GP. It's obturated with a resin sealer. Your H file will in fact break. Okay, so it's always important if the obturation is being done with a modern sealer, you need to use a retreatment file. And to remove the GP, your Dentsply retreatment files D1, D2, D3 is very good, very effective in removing the GP, but it's very stiff. Okay, so it's very stiff. You can use this file till the middle third. But when it comes to apical third, you cannot use any rotary files. Okay, why? Because first thing, it will not be very stiff. In curvature, it will not go. The second thing is the sizes of the retreatment files are very high. So your apical diameter will increase too much. Okay. So you should not use any retreatment rotary files in the apical 2 mm, 2 to 3 mm. And high flex remover is quite flexible. So if it's a curved canal, you cannot use Dentsply Pro Taper retreatment files. It's very stiff. In curved canals, it usually doesn't work properly. In curved canals, I would recommend Coltine high flex remover. But the thing is, the cutting efficiency is high in Dentsply. Okay, but the flexibility is more in high flex remover. So you need to select accordingly. If it's a curved canal, you go for high flex remover. If it's a straight canal where the GP is more, you need to remove the GP very fast. Then you can go for Pro Taper Dentsply. And it is recommended that sometimes you should not use endosolve in the pulp chamber. Okay, you should start using endosolve in the pulp canal. Why? Because and also you should not use endosolve in the apical third and all. You need to use only in the coronal third and the middle third. Your GP remover, why it shouldn't be used in the pulp chamber is when you're going to use the GP remover in the pulp chamber, it will actually dissolve the GP in the pulp chamber. It will actually hinder your visibility, and also what it will do is it will dissolve the GP, and those GP will go and get clumped in the pulp floor. Okay, so it's not recommended. So don't use your solvent, GP solvent, in the pulp chamber. You use it only in the pulp canal. Initially you remove it with your removers, your rotary files, and then when you have reached a little bit inside the canal, then you start using this your endosolve or your any GP remover. Okay, so this is my recommendation for retreatment. Other than that, whenever you're doing a retreatment, your canal enlargement should always be minimum 25.6%. So your final file should be at least 25.6% or 36%. Only when you're enlarging till 25.6% or 36%, you will be able to irrigate till the apex. So whenever there is a retreatment case, there will be lesion. Apical lesion will be there. So only if it is a 6%, you will be able to irrigate. The irrigant can reach up to the periapical region, and you will be able to sterilize the canal properly. And also it's always better to use a flexi needle. Okay, so this is an endoflex needle. So this is recommended when you have a lesion. So in retreatment also, you should enlarge at least till 25.6%, even if it's a molar also, 25.6% you need to increase. Only then your needle can reach the apex and you can be able to disinfect the canal and the apical region properly. And also intracanal medicaments is a must. Okay, so for retreatment, you can never do single sitting RCT. You have to place intracanal medicament, and intracanal medicament never use premixed calcium hydroxide. So premixed calcium hydroxide efficiency will be very less. Always buy calcium hydroxide powders. Okay, calcium hydroxide powder, freshly mix it with distilled water. Okay, freshly mix it into a paste with distilled water and load it into the canal with lentulospiral. So why, when you're going to freshly mix it, the release of calcium ions are going to be very high, and you will get a burst, that is your alkaline burst will happen at the fifth day. Okay, so that alkaline burst will not be as high as your freshly mixed preparation than your pre-mixed ones. So you should always go in for freshly mixed calcium hydroxide, mix it with distilled water, load it inside the canal and leave it for at least 1 week, and then only you have to obturate if you're going for retreatments. Okay, so this is my today's retreatment outcome. So I hope it was useful for you guys, and I will just start with question answer session. 1 second, doctors. I will just start with the question answer session right now. Yeah, let me start with the first question. Dr. Amreen has asked file retrieval techniques, crown lengthening procedures. Doctor, file retrieval techniques, there are many techniques, doctor. So if you want to do file retrieval, you have to do it with microscope. And there are like plunger kits are available and BTR pens are available. So there are two techniques usually done. That is, one is you just plung it out. That is, you lock the file and pull it out. Or you just put a loop, a hook, and you lock the file and pull it out. So these are the most common retrieval techniques. And without microscope, with loops, if you want to retrieve, you can retrieve only up to a middle third or a coronal third level. So if you want to retrieve a file that is in the apical third, microscope is a must. And then coming to crown lengthening procedures, so you can do it with scalpel or your laser, doctor. It depends. So your biological width is 2 mm. So you should not violate your biological width. So that is the only requirement for crown lengthening. And Dr. Soumya, if we decide to leave a file behind, is it better to use bioceramic sealer for obturation, or can we use resin sealer? Resin sealer, I do not recommend at all. Okay, so resin sealer and silicone sealer, I don't recommend at all. So sealer is very good, but the healing property is not very good. Sealers are very hard, but it doesn't bond with the tooth properly. Okay, the penetration of the sealers are not good. Resin sealer and silicone sealer, it doesn't penetrate properly into the canal. So usually what I recommend is either you go for a calcium hydroxide based, MTA based, or a bioceramic based sealer. If you're leaving the file behind, the first thing is the patient should be asymptomatic. The second thing is the canal should be disinfected properly. That is, you have to do irrigation protocol. Ultrasonic activation or sonic irrigation activation is recommended to completely disinfect the canal. The second thing, you can place intracanal medicament as well to disinfect the canal, and then you can go for obturation. So no matter what obturative material, like you can use calcium hydroxide, MT, or bioceramic sealer. If you have disinfected the canal properly, it will work well. And bioceramic sealer, since they have antimicrobial properties as well, they will have a very good healing. Okay, so it is recommended to use bioceramic sealer. But before that, you have to disinfect the canal using irrigation, proper irrigation, and your intracanal medicament placement is also very important. Then if I obturate with a broken file 3 to 4 mm away from the apex, doctor, one thing is whenever the broken file is 3 to 4 mm away from the apex, the chances of failure is high. Okay. Why? Because there is a dead space below your file. There is a space where you haven't filled with any filling material. Okay, and no blood supply also. No, for example, I will just draw it here. So we are having a canal like this, and you are having a broken file here. Okay, for example, now this space here, it's completely not filled. This space here is completely not filled. Whenever you are not going to fill this space, it's going to be a dead space. So here you will have regular blood supply. Okay, the periapical region, you will have regular blood supply. And whatever there, even if there is a foreign object or even if there is a bacteria here, our body's immune system itself will clear this out. But here you don't have any blood supply at all. Okay, so what happens is the bacteria, if it is present here, it will freely actually grow and it will form a colony, and failure is inevitable. Okay, failure is inevitable. In fact, there are studies done like where the obturation is done short, failures are more than even if you kept beyond. Also, the failure is quite less. Okay, so even if you keep the GP beyond, also failure is quite less compared to short obturation. So always, if you're having the apex is lesser, uh, your file has broken 3 to 4 away from the apex, the first option would be to do bypass. Okay, the first option would be to do bypass. Only when you are not able to do bypass, you if the patient is asymptomatic, you can keep the patient under observation for 3 months, but you need to inform the patient. Okay, so anytime the failure might happen, anytime the failure might happen, the only option is to do bypass. That would be the best option to do. If you do bypass, there won't be any issues, or at least place intracanal medicament, make sure it's completely disinfected. And if the 3 to 4 from the apex, right, that space, if it's already, you have irrigated, or the file to broke, the file to break is not the initial file. So for example, if I start doing BMP, S1, S2 did not break, F1 only broke, then the possibility of reinfection or failure is quite less. Why? Because when I did my S1 and S2, I have actually disinfected the canal. Okay. While coming to F1, it was quite like I have already, irrigated properly. So disinfection has already happened. So if the file is of higher size, not the beginning files, then also chances of failure is less. And also sterile file. So if you have autoclaved your files, if you haven't, just put spirit or something and repeated use on next patient, then also the failure is inevitable. Okay, so your the file which has broken inside the canal, if it's not sterile, if it's not autoclaved file also, then also the failure might happen. Okay, so it's always better to do bypass. If not, you can observe, and if no symptom, you inform the patient and you can proceed with crown. uh, Bioceramics, doctor, it's just antimicrobial properties there, because tricalcium silicates. So everything which contains calcium is same. Okay, they will release calcium ions. They will create a alkalinity inside the canal. So if you're giving a calcium hydroxide, the release of ions will be less. When it comes to bioceramic or a MTA, the substantivity is more. That is, release of calcium is regularly released and more amount of calcium ions are released, because of which the antimicrobial efficiency is more when it comes to bioceramic sealer. Right now, if you want to do a best endo, it's always better to go with bioceramic sealer. If not, if you are not affordable, like if you are not able to charge the patient more, you can go in for calcium hydroxide sealer as well as an economic option. So there are very good calcium hydroxide sealers as well available in the market. So the antimicrobial efficacy will be less, but it will be better than your zinc oxide eugenol or other sealers. Either you can go for calcium hydroxide if you want the economical option, or you can go for MT or bioceramic sealer. So all are basically same. It's based on calcium, antimicrobial action, alkalinity. So this is the basic principle. And additional to it, your bioceramic sealers are known for good penetration and flow, because they have a little bit of silica particles in them, because they flow very well, and they are like, they penetrate very well into the dentinal tubules. Okay, so they bond very well with the tooth structure. So sonic irrigation size. It depends on the canal size, doctor. Sonic irrigation, the depths depend on your canal size only. And can we proceed with RCT if the decayed tooth is grade 2 mobile, but the X-ray doesn't show more bone loss? Will there be compromise? Doctor, we can proceed with RCT even if it's grade 2 mobility, but provided you need to know the reason of bone loss. Okay, so if the X-ray is not showing any bone loss, mostly the mobility might be because of the lesion. That is your endo lesion itself. Sometimes if there is pus discharge or anything like that, or endoperio lesion more commonly, in those situations the bone resorption will be more. It will not be very much evident in the X-ray, but the tooth becomes mobile because of the lesion. So as you proceed with the endo treatment, mostly the lesion will subside and the mobility also stops. Okay. But whatever might be the reason for the mobility, you need to know the reason. Okay. So if the mobility happened because of perio, okay, because of your bone loss or gingival recession, furcation involvement, then you need to rectify that also. Okay. You need to know the prognosis of the tooth in general. So you know that prognosis list, right? What the perio people do whenever you have a grade 2 mobility or grade 3 mobility. Only when you think that the periodontically, if the tooth is having a good prognosis, then you can proceed with RCT. Okay. Sometimes the mobility can be because of your endo lesion itself. In those cases, you will not find any bone loss, but the tooth will be mobile. The mobility will automatically get arrested as the lesion gets arrested. So in those situations also, you can go for RCT. And whatever might be the thing, like even if it's grade 2 mobile, we can do RCT, but make sure you inform the patient priorly, okay, that the tooth is mobile. So when we do RCT, the prognosis can be less. Okay, the tooth might become mobile more after the treatment. Also, it might it might fall out after 5 years. The prognosis might be less, so you need to inform the patient about that before starting the treatment. If the patient is willing to do beyond that also, then you're ready to go. You can do even RCT in grade 3 mobility also. How is plus sealer for re-RCT? Doctor, I don't recommend plus sealer. I don't recommend any silicon-based Coltin Rocco, Cutaflow and all. The only thing what I recommend is bioceramic sealers. The first option would be to go for your Septodent bioceramic sealer, or you can go for Safe Endo bioceramic sealer if you want a economic option. Safe Endo bioceramic sealer, or alternatively, if you want more economic option, you can go for MTA Philapix. And even Coltin bioceramic sealer is available right now, which is only 3K, I guess. Yeah, you can go for Coltin bioceramic sealer, or you can go for MTA Philapix, or you can go for Care Seal Epix, which is a calcium hydroxide based sealer. So I recommend only calcium hydroxide based sealer, MTA based sealer, or a bioceramic based sealer. I don't recommend any other sealers. Okay, I have done personally many studies also comparing these three. And in my own study itself, I got bioceramic sealer and MTA sealer only penetrates very well into the canals. Okay, and if file is away from apex 3 to 4 how to bypass? A little bit in detail, please. So bypassing is not quite easy, doctor. Like you need to just bend the common file which you will be using is a definder. Okay, definder file. You will be you just need to bend the tip, and you need to put it. Usually the files actually they fall towards the external surface of the root, that is towards the outside. Okay, whenever a file breaks, they fall towards the outside. You just need to bypass a little by little. So you just need to check whether the definder is getting dismantled, like it will get intertwined. So if it's getting intertwined, you just need to discard the file and start with a fresh file. So you will be doing bypassing for almost 1 to 2 hours. It requires too much of patience and a definder, a complete box of definder. You just need to bend the tip, directed towards the inner curvature of the root, and little by little, and you take out the file and see if it is not intertwined or crumbled, you can repeat use it. If it's crumbled or intertwined, you discard and start with a new file. So you'll be using a 10 size definder. Okay, 10 size definder, you will be bypassing a little by little. So it's actually you can try what I recommend is bypassing is cannot be teached. Okay, I can tell you all these things, but some things are done only in hands-on. Like you can buy a block. Okay, there are resin blocks available in dental cart and all. You can buy a block, try to break files and try to do bypassing in the resin block and see. So you will be able to see how the file goes, and how you can how you can negotiate and all. So it's always better bypass. You can try in resin blocks. You try it in hands-on in your clinic itself. No need to go for any attend any hands-on and all. It's all hand skills only. You can buy a resin block, buy definders, break a file inside the resin block, try to bypass. Okay, from inner curvature, definder, bend the tip, try to send it inside. Little by little, you will get to know how it gets bypassed, and the same thing you do it on the patient. Clinical RCT, I don't know, doctor. There are many books. I need to put a very big list here, because there are nearly 20 to 30 books. Only after reading 20 to 30 books, you can do a good RCT. That is the truth here. But in general, you can go for Ingle, Cohen's, and there is something called Torabginate and all. So some authors are there which you can get a good RCT knowledge from. And then 1 to 2 extrusion of 4131 due to some trauma. After 2 weeks of splinting, 31 is completely firm, but the 41 is still same grade 1 mobility. No major bone. Yes, doctor, you can do. Grade 1 mobility because of trauma, it will get arrested. You can proceed with the treatment. So the mobility can be because of the lesion itself. So as the lesion gets arrested, the mobility might stop. So you can proceed. Sometimes we give open dressing to the patient in first sitting during RCT. Is it correct? It's never correct. You should never leave the patient with open dressing only if it's a weeping canal. Like as soon as you put access cavity preparation, like pus discharge is coming out of your canal or the patient is having a very huge swelling. Okay. In those condition alone, you can give open dressing. Okay. That too, not more than 1 or 2 days. So, according to the recommendation, you should never, according to the protocol, you should never leave the tooth open. You can leave it open only in evident pus discharge or swelling cases, only 1 or 2 days. So, if I'm like doing starting a RCT today, I will be doing access cavity preparation, enlarge the canals. Okay, that is very important. Enlarge the canals, and I will leave it open for only 1 day so that the pus can drain. Okay, so the pus can drain. I will enlarge the canal to facilitate this drain, and I will leave it open only for 1 day so that complete pus drainage can happen. Next day itself, I will call back the patient and I will place intracanal. I will just irrigate and disinfect once again, and I will place intracanal medicament and give close dressing. So this is the protocol which we follow right now. So only if there is a evident pus discharge or swelling is there, you can leave it open, but not more than 1 or 2 days. Okay, doctor. So the question answer session is over. Any like any suggestion about your what topics can be taken in future or anything, you can just contact our academy number, and also you can contact our academy to know about the courses as well. So we conduct two types of course in general. Like one is about the aesthetic dentistry and another about the comprehensive endo, both mentored by me, and both are like 10 days course with 7 days online classes building up the theory before going into hands-on, and the 3 days will be completely with hands-on. Okay, so 3 days you will have complete hands-on, and we have like launched a course right now, an online course where I will be teaching you about a digital smile design. So this is a very much essential tool for every general dentist. Okay, not only a aesthetic dentist. So this will actually convert your patient. So that is very important. So no matter how much skills you learn, you can, even if you don't have a skill. For example, I don't know how to do surgical extraction. Okay, even if I don't know how to do surgical extraction, nearly at least 10 surgical extractions happen in my clinic per week. Okay, I call consultants only for surgical extraction, or sometimes my husband comes and does. So like it's always we call in consultant only. Then also cases keep happening. Why? Because I am able to convert the patient. Okay, so that is very important. Even if you don't have a skill, you don't know how to do a veneer preparation, or you don't know how to do an implant, or you don't know how to even do a crown and bridge also, it doesn't matter. If you know how to convince the patient, that is the major thing. So your digital smile design is completely about that, like how you can convince the patient, how to evaluate the smile, and what are the key points of a smile design, and then how we can use a 2D smile design software to show the patient the after results. Even if it's for an ortho treatment also, if the patient is wearing a metal braces, how it will look. If the patient is wearing a ceramic braces, how it will look. So all those things are available in the software. Not only with the veneers, even a single crown also. If a one is not actually there, one only you're going to do a treatment, you're going to place a crown there or an implant there, how it will look. So you can almost show everything to the patient in nowadays. The digital smile design is not just limited to veneers or your composite veneers or ceramic veneers. Right now it's like a contemporary one. It's a patient conversion tool. So we are conducting this the coming Sunday, like 5th July. So I hope it will be helpful for all the participants. Many of the everyday essential participants who have been attending from North India and from around the world. I literally thank you all. Even if you're not able to, like, I keep getting inquiries about whether I will be able to conduct this advanced aesthetic course itself through online. Like, I give them the kit and hands-on happens in online. Participants have been asking me, many leads have been asking me. I am currently trying to do it, but I don't think so how effectively I can do it. But right now, what I'm able to provide for the like for my colleagues or friends who are present away from me, North India or away from me, the only thing what I'm able to provide them is digital smile design course. I hope it's useful for many, and I hope like it will be useful and we can continue giving that course as well in the future. Okay, so thank you, doctors. If any doubts, you can just ask in our academy page. Thank you, doctors. Thank you. So if I like right now I got a question, I will just cover that and I will just wind up. So if I can't completely remove the pulp in first visit, can I place deep plug? Doctor, it's very much recommended that you should remove the pulp in first visit, or else at least use sodium hypo to remove the pulp. Okay. So depulp, it's not recommended because it has a formaldehyde or something in it, formalin in it, which actually it's a carcinogen, so it is quite contraindicated. It's recommended to remove the pulp. You can use sodium hypo. Without sodium hypo, there is no endo. Even if there is no pulp, also you have to use sodium hypo. In case if it's a hot tooth, or if you think that it's very painful for the patient, if it's completely unavoidable, then you can place depulp. Okay, so it should be your last option, not the first one. Yes, doctor, we will upload it on YouTube. Okay, so even if you guys were not able to attend 5 minutes or 10 minutes, you can go and see our YouTube channel. It will be uploaded. Today's online session will be uploaded. Okay, thank you, doctors. Thank you.